Hello, welcome. Thanks for taking the time to join us on this seminar. So my name's Iman Jama. I'm a full-time practicing optometrist in the UK, and I'll be speaking to you about diabetes and diabetic retinopathy. So this is actually a vast topic, and unfortunately in the time that I've been allocated today, there's no way I'm going to be able to cover everything on that topic within that time. So I'll try and get through as much as possible as I can today. And hopefully anything that's not covered today will be covered in the future seminars as well. So make sure that you do keep up to date with the Vision Arcade on the Instagram page as well, and you'll be up to date with it and know when our next upcoming seminars will be. And also, just before I get started as well, the way that I personally like to do things is I like to start from the basics and cover the foundation so you can build on a solid foundation. So that's how I set my presentation to be out today. But hopefully you'll all still be able to take something from it and it'll be beneficial to you all. If anything, at least it'll serve as a reminder to the basics as well. And I think we all can benefit from a reminder every now and then. So yeah, so we'll get started. So with regards to the content, so I'm going to quickly be covering hyperglycemia and what diabetes actually is. And then I'll go on to talk about systemic pathophysiology, the risk factors for diabetic retinopathy, and then cover and finish off with retinal pathophysiology. So just to start with a definition, hyperglycemia can be defined as excessive concentration of glucose circulating in the blood. In terms of units, anything less than 7 millimolars per liter is classed as normal, whereas 7 to 11 is classed as pre-diabetic, and anything above 11 is diagnosed as being diabetic. This is based on repeated readings, obviously, taken 2 hours after eating. The figures for fasting, for the glucose levels within the blood when fasting is slightly different, as it would be less, obviously. So diabetes is divided into two types. So you've got type 1 and type 2. Type 1 accounts for about 10% of diabetics and is more common in childhood, so typically occurs before the age of 40. It is an autoimmune condition in which the beta cells that produce insulin are destroyed by a specific antibody. Thus, type 1 diabetes requires lifelong treatment with insulin. Type 2 diabetes accounts for obviously the remainder, which is 90% of the diabetics. Unfortunately, many of them remain undetected for many years. This is where the body's insulin is produced, but not enough of it for the body's need, or the body becomes resistant to the effect of insulin produced. It is a progressive condition requiring lifestyle management, as studies have shown strong positive correlation with obesity. However, over time, most of them will require oral drugs and/or injections. So in terms of symptoms, although these symptoms are often common to both type 1 and type 2, they're typically more acute in type 1. So they can develop over days or weeks in type 1, but take longer, so months to years in type 2. So you've got polyuria, which is increased urination, particularly at night, increased thirst, feeling lethargic, slow healing of cuts, itching and skin infections, blurred vision, which arises from metabolic changes related to blood glucose levels, which alters the refractive index of the crystalline lens. And then you've got obviously constant hunger and unexplained weight loss. So systemic pathophysiology. Cells convert glucose into ATP, which is a chemical that the cells can break down and release energy, which enables them to carry out their primary functions. So endocrine cells, endocrine being relating to hormones, within the pancreas, in the region known as islets of Langerhans, secrete insulin, which regulates the blood glucose levels. Insulin then acts to reduce the glucose output by the liver and increases glucose uptake by the skeletal muscles and other tissues. So more glucose is stored as glycogen. Glucagon is another hormone produced by the pancreas, which stimulates breakdown of glycogen into glucose for the body to use. It's quite easy to get them mixed up, so be careful with that. So glycogen is stored in the liver, whereas glucagon is a hormone. And it's actually the balance between these two activities that dictates the blood glucose levels. So incidence refers to the probability of a patient being diagnosed with a disease during a given period of time. This is currently rising due to increasing risk factors such as rising obesity. So obese men are 6 times more likely to be diagnosed with diabetes, whereas for obese women, it's up to 13 times. Note that obesity is only associated with type 2 diabetes and not type 1. So the graph shows the positive correlation and steady % increase over time. Prevalence refers to the total number of cases of disease existing in a population. So 1 in 11 adults, that's 1 in 11 adults worldwide. And that data is from the IDF as well, which is the International Diabetes Federation. So they've got a good website on there that's got a lot of stats and information about diabetes as well. So I would advise that you do have a look at that site. And on there, they've also said that 3 in 4 people with diabetes actually live in low and middle income countries as well. So the reasons for this could include limited access to healthcare services in these countries, inadequate training, lack of awareness of symptoms amongst the general population. So just to compare, the figures in the UK are sort of about 6%, whereas in Nigeria, it's about 3%. So it is a little bit less, but there's a lot of people who are actually diabetic. So these stats go to show the importance of the role that we play as optometrists and healthcare professionals in detecting and managing diabetes and diabetic eye disease, especially since the retina is the only structure in which we as healthcare professionals can see the blood vessels clearly without having to perform any form of invasive procedure. So you don't have to cut someone up to be able to see the blood vessels. You can see them clearly just by having a look at the retina. And from that, you get a lot of information about someone's health. So bear in mind that these figures are probably excluding those patients who are actually diabetic but haven't yet been diagnosed yet. So in other words, just from looking at these figures, it goes to show how much work we've got to do as healthcare professionals. So diabetic eye disease also includes other non-retinal changes. So although today I will be focusing on diabetic retinopathy, but don't forget about these other changes as well. So you've got refractive changes, which can be transient, so if the prescription sort of fluctuates and changes with time, or permanent, so you get like a myopic shift. And that's due to the increased thickness and curvature of the lens. You also get corneal changes. So this is where the cornea takes longer to heal and decrease in sensitivity. So it's particularly important to think about this when fitting patients with contact lenses as well, and increased risk of contact lens infections, etc. Cataract, which is the common cause of cataracts, diabetes obviously being the common cause of cataract. Glaucoma, so you get an increased risk of primary open angle glaucoma, where the new vessels grow in the iris, which can lead to or cause angle closure glaucoma. And then you've got the cranial nerve palsy as well, changes. So although this is not very common, but 1/3 of patients with cranial nerve palsies also happen to be diabetic. So risk factors for diabetic retinopathy. So it can be sort of grouped and divided into 2 groups. So you've got the non-modifiable ones and the modifiable ones. So in the non-modifiable risk factors, you've got genetic factors, ethnicity, gender, age, and duration. So with regards to ethnicity, studies have sort of shown that patients from Pakistani or Bangladeshi background are at higher risk, and that's followed closely by sort of African patients. And then with regards to gender, the studies have shown that men are 56% more at risk than females, and with duration, obviously type 1 diabetics, 90% of them will develop diabetic retinopathy over a period of 20 years, whereas it's 60% in type 2 diabetics. So it's important to try and educate our patients and try and control the modifiable risk factors as much as they can to reduce the risk. And these include trying to control their glucose levels, blood pressure levels, cholesterol levels, BMI, and smoking. I'm just going to quickly check the chat. Okay, that's fine. Because I'm not going to be opening the chat box, if anyone wants to say anything, then I'd ask if you could just speak to me. That'll be easier rather than having to read the chat box. So before I get started on the topic of retinopathy, I just want to say that this is based on the sort of assumption that you have basic understanding of the relevant anatomy, mainly being the retina. So this part of the presentation will require a bit more sort of mental effort, so please be patient with me. So diabetic retinopathy is the most frequent cause of new cases of blindness registered amongst the adult ages of 20 to 74 years of age. And in the red, you've got the definition from the Royal College of Ophthalmologists. So it says diabetic retinopathy is a chronic progressive sight-threatening condition, which you get the retinal changes as a result of hyperglycemia. So it's also worth reminding ourselves of what level of vascular system we're talking about when we consider the effects of hyperglycemia. So on this illustration over here, it shows the vascular architecture of the arterial and venous system and how they interact via the capillary beds, which is sort of around here, found within the retina. So that's the level that we're sort of talking about. So you've got the pathological changes in the retina. The first one being parasite loss. So parasite cells which you can see sort of here in the blue, encircle the endothelial cell layer of the blood vessel wall, which is the red bit. So it sort of covers it and goes over it, and you can sort of see it nicely in this grey picture over here as well. So they provide vascular stability and prevent uncontrolled growth of new endothelial cells. So the loss of these cells results in reduced vessel wall strength, and that leads them to bulge out, and that's what you call microaneurysms, basically. So they bulge out, it bulges out into the retinal, into the tissue surrounding that area. So this is a high magnification image of stained tissue showing the retinal capillary bed. So you've got the little microaneurysms seen in the little black arrows. So you've got one there, one there. So all these little round circular red regions are your microaneurysms. And that's actually the earliest visible sign of diabetic retinopathy. So in the red arrow over here, so that shows the large arterioles. The blue arrow over here shows the venules, and then the green arrow shows your capillary bed, which actually isn't visible with the ophthalmoscope. So that'd be quite hard to see in the ophthalmoscope, but you would see the little red regions there. So following the loss of the parasite cells, because of hypoglycemic changes, you get increased vascular permeability. So this leads to the breakdown of the blood-retina barrier. So this is a term given to the process by which the beneficial components of the arteriole's contents, so the oxygen and the glucose, is transmitted to the nearby neural structures, and the harmful components are prevented from entering the retina. So that's the barrier. So it lets all the good things in and prevents the bad from entering. So it regulates the permeability of the retinal blood vessels. So this is achieved by what we call tight junctions between the endothelial cells of the blood vessels' outer walls. So the breakdown of the blood-retinal barrier compromises the tight junctions. So now you get leaking of the blood content into the surrounding tissue. So you've got red blood cells, which sort of leak out, and they lead to what we call dot, blot, and flame hemorrhages. Plasma fluid sort of leaks out, and that leads to retinal edema. And then when you get lipid that sort of leaks out, you get hard exudates forming. So the above factors eventually lead to progressively reduced retinal blood flow through the capillaries. So as the pressure drops due to the breakdown of the barrier, the capillaries cease to transport any of the necessary oxygenated blood to the surrounding tissue. So this is what we call capillary closure. And this is tightly associated with retinal ischemia, ischemia being inadequate blood supply to that particular area. So it's a good indicator of where subsequent neovascularization will occur. So retinal ischemia is the first visible sign, and you can sort of tell by what we call cotton wool spots. That's what you get. So cotton wool spots are also known as soft exudates. So you've got hard exudates and you've got soft exudates. So the soft exudates are fluffy white lesions, which are found in the nerve fiber layer. So due to their inner retinal location, they obscure and sort of cover the underlying retinal blood vessels. And if you see the cotton wool spots, that indicates an area of retinal ischemia caused by occlusion of the capillary arterioles, basically. So just to summarize that section and just that part, what I've just said. So you've got the loss of the parasite cells, which leads to microaneurysms, which leads to breakdown of the blood retinal barrier, and that causes an increased permeability, and you get leaking, which causes the drop in the pressure within the vessel, and that leads to capillary closure, and then you get ischemia, and cotton wool spots are the first sign of ischemia, basically. So we've got two more signs to get through. So the next one is intraretinal microvascular abnormalities, also known as IRMA. So these are capillaries that become dilated to the point of being visible via the ophthalmoscope. So initially we said that capillaries, these small capillaries are actually quite hard to see with an ophthalmoscope, but if you do, then this is actually IRMA. So they follow a tortuous path, and they're frequently found near cotton wool spots. So they're actually an alteration of pre-existing capillaries. So they're not new vessels, and they normally don't leak. And then you've also got venous beading as well. So that's severe ischemia, in which you get irregularities of the vessel wall, and you get bead-like profile. So it sort of looks like beads or sausages over here. And then this is the capillary bed, which normally isn't visible, but because it's now classed as IRMA, you can actually see it. So neovascularization. I know I'm getting tight on time, but I'll try and cover as much as I can. So all the diabetic retinopathy signs we've covered so far represent non-proliferative diabetic retinopathy. However, neovascularization is the hallmark of proliferative diabetic retinopathy. So you've got cytokine, which is a protein known as vascular endothelial growth factor. This is produced by ischemic cells within the retina to stimulate new blood vessels forming. So it's the driver for, this protein is the driver for new vessels to be formed. So it acts on the receptors on the surface of the endothelial cells, resulting new vessels. So you can see them sort of attaching here, and then you get the tube formation, and then it elongates into new blood vessels. So the features of these new vessels, they are fine, thread-like patterns of growth, and they randomly crisscross paths of new blood vessels. So it's sort of classed and divided into what we call new vessels at the disc, so you can see them there, and new vessels elsewhere as well. So the black oval over here as well shows fibrovascular proliferation, which is kind of like tissue supporting the framework and acts as scaffolding for developing new blood vessels. And then you've got your blood hemorrhages as well, and venous looping as well. So in terms of classifying the diabetic retinopathy, so it's sort of classified into mild, non-proliferative diabetic retinopathy, moderate, severe, and then very severe. So with mild, you've got at least one microaneurysm, retinal hemorrhage, hard or soft exudates. And the hard exudates are sort of these yellow waxy lesions with distinct edges. Moderate, you get microaneurysms and or dot plot hemorrhages in at least one quadrant. You've got soft exudates, which we said were cotton wool spots. And then you've got venous beading, sort of like the sausage looking or beading looking blood vessels and and then severe is classed as microaneurysms and intraretinal hemorrhage in all four quadrants, venous beading in two or more, and then moderate in at least one quadrant. So this is actually known as the 4-2-1 rule. And then in severe, you've got any of the two features as well. Whereas with proliferative, it can be any of those. And then we've said that you've got the new blood vessels, which are weak and they leak. So they lead to the bleeding into that area as well. So you've also got maculopathy. So this can actually occur at any stage of diabetic retinopathy. It doesn't have to go in that order and sort of go through the proliferative stage and then maculopathy. You can actually get it with background diabetic retinopathy, for example. So it's the most common cause of reduced vision in diabetes in the working age group. Edema is actually difficult to spot with an ophthalmoscope, but probably a bit easier to see it with a Volk, so indirectly. And maculopathy, again, is due to the breakdown of the blood-retina barrier, resulting in leakage of blood product, such as fluid. So you get any of the following signs in or around the macula: edema, hard exudates, or ischemia. So you can sort of classify it a little bit more. So hardly any retinopathy, well, no retinopathy, then you're just basically diabetic, that's okay. Background, which is mild and moderate. Pre-proliferative is severe and very severe, and the proliferative is where you get the new blood vessels forming, and then maculopathy as well. So just to quickly go over the complications of diabetic retinopathy, don't forget that you also get vitreous hemorrhage, tractional retinal detachment, rubeosis iridis, glaucoma, and blindness. The blindness could be due to various reasons, including non-clearing vitreous hemorrhage, neovascular glaucoma, the retinal detachment, or the macular ischemia. So just to summarize, make sure that you do have a good understanding of the variety of retinal signs and how they relate to the anatomy of the retina. That just simply aids in your differential diagnosis. So always use your clinical judgment and go with your gut instinct. Ask yourself, do you need to dilate this patient? Ensure that you've examined the peripheral retina well. That always goes without saying. And then have good knowledge of local referral protocol. That way that the patient is managed appropriately as well. So I've just put these three websites on there. So the first one was the one that I used the stats from, which has a lot of information. So does the second one. The third one is pretty good in terms of doing a quick quiz just to test your knowledge on the topic of diabetes and diabetic retinopathy. But that's pretty much the end of my presentation. So once again, I'd just like to thank you for your time. I hope this was somewhat beneficial to you all. So yeah.